I'm the new intern for the county administrator.
Take about 3 or 4 minutes.
Oh gosh, okay.
You're about
Well, it's nice to meet you all. I don't know if you heard me earlier, but my name's Emily. I'm the new intern for the county administrator's office. Currently living in Ypsi, going to Eastern for a degree in, political science. Hopefully to earn my master's with public administration. Really enjoying being in Jackson. Never been here before I started interning, but it's a lovely area, and I'm enjoying interning, so.
It's been really nice up till now, right?
Well, I certainly didn't expect to do this, but here we go, so.
No, you did great, and we appreciate you being here, and you'll find it to be a wonderful experience, I'm sure, especially working with Deborah down there, and Delane, too.
Absolutely,
So-
they're wonderful.
Oh, excuse me, and the administrator, too.
Of course.
All right, thank you very much. Okay.
I don't know if to say good afternoon or good morning, but good afternoon, good morning. I am here to give our monthly report, and I apologize on occasion as part of my succession planning related to having my chief operating officer come and present as well when I have conflicts, so I'm happy to be here today. I do want to share a couple of things relative to things that are happening at Lifeways, and you do have in your packet the report for this month. One of the things that's not included in that report, but just wanted to give an update on that you will be getting in your June report, is the business plan for the use of the millage dollars that will go into effect next year. So the plan actually outlines the 5 areas that we had talked about when we pursued the mental health millage, and talks about the use of those dollars, actually breaks down how we will be utilizing them, what the outcomes and the intended, and the reporting back to the county for accountability. So stay tuned as I've been working on that and bringing the stakeholders and the community together. The other thing that's in your packet, an update on, as you might recall, we did get a bond for, it's been 2014 now, I think, relative to the roof repairs that we needed to have done at Lifeways, as well as the remodel for the lobby. So we're finally at that point, and so you'll see work that's happening there, and that's what that's relative to. It's about redoing the lobby, putting in some wheelchair accessible bathrooms that we didn't have for the public. And that is the area in which we're renovating. The other thing I wanted to share is relative to one of the things that we when we pursued the millage was looking at jail services. Clearly we know and support that that's a need of providing mental health services in the jail. I believe that Shannon has shared with you the fact that we were the beneficiary of a one-time, no guarantee that we would get it again in the future, but funding for the achievement of some outcomes, and we are now utilizing those dollars because it comes to us as local to put in jail services. And the status, I was hoping to get it before I came here this morning. I know that they selected a candidate, and that candidate was going through the background checks necessary at the jail. And if all goes well, we will have a full-time mental health clinician that will be in Jackson County Jail. So we're excited about that. We believe that it'll help on many levels relative to really being able to provide, they'll be providing crisis services, doing screening, doing counseling, as well as as the coordination of care that's necessary for when somebody is discharged to ensure and to prevent coming back in to the jail, making sure that those services are arranged and that they're engaging in care. So I just wanted to let you know about that. The other thing that I wanted, that's included in your packet, there's a lot of activity that we do as an organization to educate the community on mental health. So you'll see in the packet lots of training on mental health first aid, on suicide awareness training, training on trauma. That's what the ACE training, when you see that in that packet, that's what that's referring to. So there's a lot of activity that's occurring. But wanted to bring that to your attention. And then the last thing is really around what's happening, because we've been talking about it now since 2016 budget year, relative to the 17-year budget year, where they put in language to privatize the public system. So what's happening? They did, as you know, last year approve piloting and putting into play 3 pilots in the state relative to being a health plan managing that dollar first and not the current structure, which is a prepaid inpatient health plan. They did select the regions in the state that will be the pilots. And that is moving forward, but moving forward, as you can imagine, slowly. So they have delayed in the budget language that's out right now from the Senate. They had anticipated a start date of October of this year. They're actually delaying it until October of next year. If it goes through, because I know that that's in the Senate's budget proposal, is to change the implementation date of that. The other important thing relative to Section 298 is the fact that in the Senate budget, they also have language in there relative to what's called Section E, and they are removing the requirement that the health plans contract with the community mental health. So as you can imagine, as a system that's very concerning relative to what we already have placed locally for communities for providing mental health care. So it's in the Senate language in the budget, and we will have to see as the advocacy efforts and as the budget right now is in committee, what will end up happening. The other thing when we talk about the budget that's important for fiscal year, moving forward into fiscal year 19, is concerning is autism expansion occurred in the state of Michigan. So autism services have gone in Jackson County within our region. We're the 3rd highest relative to the number of people that we're providing autism services for. The language that's being proposed in the Senate budget is requiring that individuals who are seeking autism services would have to have a second opinion. The concern from the system and from myself is relative to the fact that that's not parity. There is not any other service where an individual is eligible and can request who has to seek a second opinion before they can be approved through Medicaid. We believe that isn't a violation of parity. And hoping that that does not end up staying within the budget language from the Senate. The other thing that I wanted to mention is related to the DABs and TANFs that we talked about prior, and what has been occurring over the since Healthy Michigan went into play in 2014. As you might recall, one of the intents of the Healthy Michigan expansion was to allow individuals who currently didn't have a health benefit to be able to be entitled to a benefit within the state of Michigan. And these are individuals that are not disabled. So these are individuals, when you look at when Healthy Michigan, its intent was for individuals over the age of 25 who are working, maybe 2 parents that are holding minimum wage jobs that can't get insurance through their employer. It was not intended for the individuals that we serve who are disabled and blind. What's happened is that there's been a shift over the last couple of years for individuals that were considered disabled and blind, and you had to demonstrate a disability for a year. So it's a very long process to get Medicaid through that traditional format. They've shifted over to Healthy Michigan, and why that's concerning for the system is that individuals who are considered disabled and blind are are primarily the individuals who are very chronic. Many of them have very high cost needs within our system in residential types of care. The disabled and blind, you would get a per diem, it's like a capitation rate for them at about $260 for an individual. What you receive when they shifted them over to Healthy Michigan is $26. And there's been a huge shift in which there's been a financial analysis done from Milliman, which is the actuarials, indicating that there's about $133 million loss to the system on the mental health side relative to these individuals shifting from disabled and blind, which was a benefit they're entitled to Healthy Michigan. Lot to be argued as to what the cause is, why it happened. The reality is there's been a shift and there's been a financial impact. You can't imagine that you haven't heard or seen in the paper relative to the Lake Shore regional area for the community mental health that are having challenges relative to being structurally in a deficit of $23 million. This is a contributing problem, and it has required regions to have to access their fund balance, which is their risk reserves. So it's quite a concern across the system. There is some belief that the legislatures will put in a fiscal year 18 supplemental to help mitigate that risk across the system. But those are the major things that are occurring at this moment. We will be, as an organization as well, doing our strategic planning summit. Our strategic plan is a 3-year plan, and it is we are in our last year. So we will be convening a summit in June with our board to kind of look forward as to planning for the next 3 years. So I will leave it open for questions of the commissioners.
Anybody have any questions or comments? Doctor?
Mary Beth,
Yes.
how did that get shifted from, was that the legislature who shifted the blind and the disabled over to Healthy Michigan?
No, it isn't. They're not the ones to shift. It actually happens through the Department of Health and Human Services relative to, and it's a very complicated process, so it's not easy to point a finger and say, how did it all happen? Some of it happens as a result of, it's a lot easier, I will say that, for somebody to apply for Medicaid, for traditional Medicaid, for the DABs, you have to actually demonstrate that you've been disabled for at least a year to even potentially qualify. Now, Healthy Michigan, it is not based on disability at all. So individuals going into the system and people that are up for renewal, because you have to, every year they evaluate your eligibility, even though you're been determined disabled and blind, can easily shift over because the process is easier to get them into Healthy Michigan than it is the other route of disabled and blind. So there's some belief that that process just naturally, because of the ease for people maintaining the benefit, and the benefit isn't different. That's the important thing. So if you're a person on Healthy Michigan, or if you're a person who, you wouldn't know that you qualified under Medicaid as disabled and blind. That's not something you would know. That's on our end that we know, because that's how you're determined and the funding happens. So the benefit is exactly the same, yet the payment to the system for the services is different, and that's where the concern is.
Is it that hard to get the disability? Okay, because many times in my office when I was practicing, people would come in, and if they were under 65 and so on, they'd be disabled, or they have Medicare, and that's usually because they had disability, okay?
Right.
And when I would ask them what's their disability, not many times, but there are times that, oh yeah, I was divorced 9 years ago, okay, or I have this, and I say, well, you're in better shape than I am, okay, and so on. So how do they get that so easily okay, when you say that it's difficult to get it.
It is difficult to get the traditional I mean, I used to be a former case manager and would often have to appeal some of the decisions where I felt people should have been eligible for a benefit that they didn't receive. So I can't answer that specifically. I know it is not easy to get.
Okay. And one other question under your Healthy Me programs?
Yes, yes.
Okay. How come there's only 15? Is that the capacity of the program?
It's the capacity, yes, it's the capacity of the program,
Okay.
the groups. Yep.
Thank you.
Yes, go ahead, John.
Mary Beth, just a quick question of clarification, just
Yes.
understanding all the bureaucracy. And disability, individuals who are disabled, individuals who are blind fall within, the county would fall under Lifeways? Is that, I'm just saying individuals who may be disabled or blind, is it services through Lifeways that they seek for?
Yeah, but they would also receive services, it's all care, so it's physical health care, but if they were in need of behavioral health, it would be through Lifeways.
Right, so,
Yes.
okay. And so individuals who are blind but are not necessarily need mental health assistance,
Right.
they probably wouldn't be a natural client of Lifeways, is that?
That's correct.
Okay,
Yeah,
okay,
yeah.
thanks.
Anything else? Okay, well, thank you very much. I know, obviously, the mental health, behavioral health, DD world, all the above is very difficult for anybody to understand. There's so much to it. I will say that Shannon did tell us about that money, local money, going to the jails. It's good to hear that we're going to have a mental health professional there.
Yep.
I know this is something that you and I have certainly talked about for years, I think it has been, and since we had nobody there. And obviously our board at Lifeway certainly supports that too, and obviously the board here, so I appreciate that. But I also heard you say Shannon and succession plan
Yes,
for you?
yes. Mhm.
Okay, we had this
Yeah.
conversation about you retiring, but okay, thank you very much.
Thank you.
Department of Aging, Marcy.
Good afternoon. Wanted to update you about a special diet program that we have for Meals on Wheels, and it was about a year ago that we started this option for homebound older adults who request one of the 3 special diets that we have available, either the low carbohydrate, low sodium, or mechanical soft. And the program has been going very well. In the last 6 months, 47 older adults have requested one of these special diets, and currently 33 people are receiving special diets. And we don't prepare them in the kitchen. They're a product through our food purveyor, and they're a frozen meal. And they can have up to 14 meals a week, so two meals a day, so it's depending on their preference. And we wanted to keep it simple for the participants, so we're not requiring a doctor's prescription in order for them to receive a special diet. So again, it's a home visit's done with each Meals on Wheels participant, whether it's special diet or other meals. About 550 people receive Meals on Wheels a day. And a social worker does an in-home assessment initially, and then every 6 months, and finds out what other services they may benefit from. And the fee's not charged for services, it's on a suggested donation basis. And currently, we're not able to bill the special diets to our grant resources, but we've asked about that, and nutrition requirements are going to be a little bit less stringent as far as qualifications for what can be considered a senior meal through the Older Adults Act, and so we're anticipating that we will be able to report these meals and at least get the 70-cent per meal reimbursement that's through the USDA. And to let you know, we're asking for people to submit nominations for the Senior Citizens of the Year. So if people go to our website, the nomination form is on our website. And so we're encouraging, it's either individuals or maybe organizations who have older volunteers, and we look at volunteerism since turning age 60, and there's a committee of the Advisory Council on Aging that reviews the nominations. And then they're recognized on Senior Day at the fair, and the county fair board has a plaque commemorating thanking the senior volunteer, and then the Board of Commissioners also has a resolution. So spread the word for people to please nominate.
Very good.
Okay, any questions?
Questions, comments, Marcy? Short, sweet, and very good. Thank you.
I do have one thing I want to relay recently. I try to pass along the thank you notes and appreciation that we receive. And someone spoke with our enrichment specialist recently, and her husband passed away in December, and they used to do everything together, and she started to come to Crouch Senior Center. And she said she feels really welcome. She likes being able to come to the senior center. She enjoys going to exercise classes. She tries other classes like card making and painting. There's a garden program through MSU Extension, playing euchre. And she said she lives with family, her daughter and children, and she loves them, but she knows they have things they want to do on their own, and she'd like to do some things on her own, and so she appreciates the availability of programs at Crouch Senior Center. So, thanks.
Thanks again, Marcy. Okay, D, the Health Department. Richard? One of our working senior citizens here at the county.
Yes, sir. Thank you. Good to see you all today. Had a very busy month in the month of April, if you will, to report on. I may have mentioned this previously in some of my weekly reports, but the Childhood Lead Exposure Elimination Commission, we were approved, recommended for funding. It's a small amount of funding, about $15,000, but we're pleased to be able to report to you that our proposal that seeks to establish a consent referral process from within the electronic medical record for pregnant women to the health department at the earliest point in their pregnancy has been recommended for funding. And what we would be doing is basically assessing women who agree to engage with the health department for their risk for exposure to lead. It's kind of the final piece that we've been working on for some time here in Jackson County with the community to loop in pregnant women early in their pregnancy and assess them for a risk of lead exposure, and then to offer lead testing if it's appropriate, and also based on the result that might be obtained from the lead testing, to offer lead case management home visits and follow-up lead testing to address any identified issues. Also, I didn't put this in my report, but also there's a referral mechanism to other funding sources that can actually address lead hazards in the home, whether it be through the city's 3-year lead grant program that they have with HUD, or through the Lead Safe Home program at the MDHHS level. In either case, the woman might be eligible for abatement services if in fact that's indicated. So we're really glad to see that they came through with that proposal for us. We're always kind of monitoring for emerging health issues. Not that synthetic marijuana is necessarily an emerging health issue. It's been around for a while. It's been lots of different kind of products that you can purchase even through convenience stores, unfortunately. But we did send out a request to the Chief Medical Officer at Allegiance Health for distribution of a public health advisory and fact sheet concerning synthetic marijuana containing Rodificum. I don't know if I'm even pronouncing that correctly, Dr. Tompkins, maybe you can help me, but which is associated with uncontrolled bleeding. We felt it was appropriate for us to get this out, so that advisory is part of the packet in case you have any other questions about it. Michigan is also kind of catching up with, I think, maybe a morbidity and mortality surveillance system concerning opioid surveillance. I think that this is funding that came through from the federal level to the state, and the purpose is to provide researchers, local programs, other interested parties with timely and comprehensive data on opioid-involved morbidity and mortality. So they had 3 strategies that are involved with this surveillance system: increasing the timeliness of aggregate non-fatal opioid overdose reporting, increasing the timeliness of fatal opioid overdose and associated risk factor reporting, and disseminating surveillance findings out to key stakeholders. So I'm glad to see that they put this surveillance system in place. My understanding is that primarily the information source for most of this will be from the medical examiner's office, if you will, to the state through this surveillance system. So you may hear more about that from Jill Clare. The North American Primary Care Research Group poster presentation, I kind of threw that in there. It's nice to be recognized, if you will, by others across the nation for the work that we're doing with our social determinants of health screening platform. Dr. Mike Klinkman, who I work closely with at JHN, has submitted a poster to them, and lots of the people here locally that have been working on it will be identified as co-authors with him. The Jackson Traffic Safety Commission did their award process on April 12th, and the Health Department submitted 2 proposals to them, one for the car seat safety program, one for the Safetyville program, which we do on an annual basis with the schools, and we're pleased to let you know that they supported those $10,000 fund requests, if you will, for both of those programs. Naloxone availability, working with our co-medical director, Dr. Mike Faust, we now have a small supply of naloxone available at the health department. I don't know if I previously talked about this in some of my other monthly reports to you, but within the past 12 months, we actually had an overdose situation occur in Lot A in the parking lot at the Human Services Building. We didn't have anything we could use to quickly administer to anyone in that situation, but now we do. We have a couple doses at the health department. These are part of the hospital stock, so they're not our inventory, they're theirs, but we're glad that we have that on board, and the nursing staff are getting training on how to use the product. Not in my report under personal and preventive health services, I want to give you an update on hepatitis A. You may recall that we received $20,000 from MDHHS to do some additional outreach and vaccination efforts in the community. And to date, we have actually vaccinated 80 persons, if you will, within our county jail settings, 40 probably at Channer Road and 40 at the Wesley Street site. And also, we administered 2 doses to clients at Board Free here in the community. So we have about 6 different sites that we're connected with, and we go about once a week to each one of those sites with one of our retired nurses in the casual status, and we're assessing for vaccination and administering appropriately to persons at high risk. So some good use being made of that. We sponsored with local realtor Laura Schlechte the Jackson Landlord and Property Managers Conference on April 24th, and it went very well. She was very pleased to be able to use the building rooms in the HSB, and we were pleased to be able to participate in that with her. There are a number of bills that are kind of floating through the legislature at this point in time. The statewide sanitary code proposal is House Bill 5752 and 5753. And I've attached in your packet kind of a set of bullet points, if you will, on the pros and potential cons associated with the statewide sanitary code. We're not really, I guess I would describe, opposed to them here at Jackson County and at the Health Department, because we think standardization is important to do across the state. There are some sanitary codes in place in Michigan where, at the local county level, that have as little as 6 inches of requirement for suitable soils between the bottom of a drain field and groundwater table. We don't think that's a very good standard to have in place, so there are some opportunities for improvement. We got some questions and concerns about the study that was done that kind of is driving this whole thing, which I've talked about in my report. But overall, I think the 2 primary concerns for us right now with the statewide sanitary code are, number one, we don't want this to become an unfunded mandate, because there will be time and energy that the local health department will have to expend in order to assure compliance with the statewide code. There is right now written into the code, as it stands as a bill at the legislature, the requirement for septic system maintenance inspection every 10 years. And that would be required of every property owner within the state who has a septic system that's known and operational and permitted. There would probably be a fee associated with that, but there will also be administrative work on the part of the local health department to assure that those kind of maintenance inspections take place. So there is work involved in it. The other issue that a lot of health departments have had some concern with is preemption language that might get built into this bill that would prevent us at the local level from doing anything with our own code or separate ordinance related to septic systems in the community. So that is out there, and the governor is quite supportive of moving that particular item forward. Two other items, if you will. House Bill 5638 is large capacity water withdrawal. Our concerns from the local public health perspective with this is that while the bill streamlines the approval process for large quantity water withdrawals, it also eliminates the ability for MDEQ to deny permits. We don't quite understand that. It's not make any sense to us that every situation where someone proposes a large capacity water withdrawal, that you might not run into a situation where you would deny permits. So streamlining is one thing, but also assuring that, it doesn't have an impact on local aquifers or people draw water from their wells doesn't occur either. But it also eliminates any public oversight by exempting agricultural wells from FOIA requirements, which is probably not a good idea. So Miliha's letter on this topic is attached for your information. And then the last item I had in my report today was the lead and copper rules proposal. Since the Flint water crisis, Michigan has been working to update its lead and copper rules as they apply to water supply owners and operators. The new household advisory level of 40 parts per billion of lead in water will require operators to provide those results to health departments and MDEQ within 3 days. This is significant because 40 parts per billion in water that's consumed by people is a really significant level. So I agree with the 3 days response time and reacting to it. But for clarification purposes, this does not change the EPA standard for municipal water operators to meet a 15 part per billion or less level overall on average in their water supply system. This is just saying, if you get a test at 40 parts per billion in a home within, say, the city of Jackson, you want to act on that very quickly. I think the primary thing here is, again, there's going to be more work to do if they want the health department involved in it, so providing some funding for it always becomes important. So that's pretty much my report for you for April, and I'm happy to answer any questions related to anything I've talked about.
Yes, go ahead.
When you were talking about the opioid surveillance and the numbers that you're going to get from the 3 initiatives there, what are they for? What are you going to use them for? Because you already know you have an opioid epidemic,
right?
Okay, and so on. Is it just to get numbers to see that you're doing better or less, okay, or what's the purpose of that?
Well, I from my perspective, I think that really being a lot more deliberate about the risk factors associated with opioid overdose makes it possible for us to address those more effectively at the local level. We think we know most of them, but I don't think we necessarily know all of them. So this surveillance system is probably more robust than any other process that exists right now in terms of understanding what the risk factors are that lead people to become overdosed and using opioids in the first place. So I think that's what it's about, for me anyway.
Is it more of a Lifeways or a psychiatry or psychologist realm of determining what drives a person to become an addict than this?
Well, I think that's part of it, but I don't think that's the total explanation for why people move in the direction of opioids. We already know that 75% of people in a given community that are addicted to opioids, that it occurred as a result of prescription drug use, and later when the prescription drugs run out, or they can't afford them anymore, or it's not appropriate for them to have them anymore, they move on to heroin because they're already addicted. So that risk factor is pretty clear. But there are other reasons people can end up opioid addicted that don't necessarily have anything to do with having gotten a prescription from a physician. So if opioid drugs are being purchased on the street, they're being stolen, people are buying them, the social determinants of health probably have something to do with it. So if they're having problems in personal relationships, there's domestic violence involved, they may be unemployed, they may have health issues that we don't know about, they may have low education levels, they're not employed. All those things can influence someone to deal with their problem in the wrong way. And I think that this surveillance system, I'm hoping, will capture some of that and let us know more about it.
You find that out, I tell you that exists now, okay, it does.
Yep.
Okay, but you find out now and you get numbers, what are you gonna do with that? Because this is a problem that we've had for a long time, okay, and so on. So you present it as if it's gonna give you information for a new way to do something, okay, and so on. We know that that's the problem. People can't handle the stress in their lives, or they can't do this, or they can't do that. That's more of a social service or medical psychiatric or psychologist counseling or Lifeways or something, okay, along those lines. I'm just concerned in regards to what data that's going to give you, and do you have a answer in regards to how that's going to help you handle those problems that we already know exist, which lead people to opioid addiction.
Right. Well, I think to some extent you're correct in that we already know a lot about the problem, if you will, in terms of developing strategies or programs and services that might address it. Setting up this surveillance system was actually not something we knew about when the state was developing it, but nevertheless, I don't disagree with you that I think that we know a lot about who's affected most in our community here. The drug-related report that I've shared with you previously does define lots of those risk factors already. I guess it remains to be seen exactly what the state collects and how it might be somehow more useful to us than what we already have. And I can't really answer that question for you right now.
All right.
Yep.
Thank you.
You're welcome.
Anything else for Richard? All right, very thorough. Thank you.
Thank you.
Okay, we're down to number E. This will be an action item. This is the medical examiner's cremation fees increase. There is documentation there from Dr. Mano that was sent to us. Hopefully you've had a chance to look at it. It's increasing from $50 to $75, and the doctor does explain why. Do we have any questions or comments before we make a motion on this? Okay. I'm waiting for a motion.
I'll make the
Motion and support. This will go on to the full board. All those in favor, signal by saying aye. Opposed, nay. All right, thank you very much. Now, we are down to 5A, claims. All right, thank you. All those in favor, signal by saying aye.
Aye.
Opposed, nay. Okay. Other minutes. We have none. June reporting schedule. We have none, so we don't have to be here. Okay. Back down to public comment. Public comment, public comment. Nothing. Okay. Committee members' comments. Anybody or anybody here? Everybody wants out of here. Okay. It is 12:41. We are adjourned at the call of the chair.